Good afternoon, ma'am.
Good afternoon, everyone. On behalf of IAP technical team, I welcome you all. I, Dr. Jaspreet, welcome our resource person, Dr. Sendil sir, and our today's moderator is Dr. Yashoda ma'am. She is state coordinator for Pondicherry, and she is pediatric physical therapist. Before over to our today's moderator, I request all the participants please like and subscribe IAP India YouTube channel and Facebook page for watching all online webinars. Over to you, Yashoda ma'am. Please moderate this session. Thank you so much. Ma'am, start.
Thank you, Dr. Jaspreet. A very good afternoon to all the participants today. We have with us our state president, IAP for UT of Puducherry, Dr. Supriya K. Vinod. We have with us today Dr. Abhirami K., joint coordinator, IAP Women's Cell Puducherry, Dr. Simulia Dhinju, sub-coordinator, IAP WC Women's Cell Puducherry, and Dr. Saranya as sub-coordinator, IAP WC Women's Cell Puducherry. And with immense pleasure, I am welcoming our resource person, Dr. B. Sendil Kumar, who is a postgraduate in adult neurological rehabilitation with 15 years of experience, 10 years of community physiotherapy with Government of Puducherry Community Health Center, Karailam Pakam. He is proprietor at Ram Physiotherapy Center. He is founder of Layers, a Movement Priority Fitnessium. He's a certified manual therapist, certified therapist in many contemporary therapies, including all taping schools, and he's an accredited movement therapist from UK. So a very warm welcome to you, sir, and we are looking forward for knowledge, immense knowledge from you. Thank you so much.
Thank you. Shall we start?
Yes.
Yes, sir.
Yeah. So, good evening all. I take this opportunity to thank IAP and IAP WPC Pondicherry chapter for giving me this opportunity to share my clinical knowledge about osteoporosis with co-professionals. I take this opportunity to thank Supriya ma'am, my principal, my guide, my mentor, who has actually, no words to actually spell her out in my life. She has done many things to me. And Yashoda ma'am, she's a sister like mine. Thank you both to bringing me to IAP. Okay, this session is going to be on osteoporosis, but rather I will say it's on misinterpretation. Okay, so I've actually put a still there actually. So it states that how the customer explains it to an architect and how an architect takes it around. The same thing happens in our industry where someone comes with a movement dysfunction or an impairment and then asks for movement freedom. Okay, the first picture is about actually a tree and a swing attached to it where we need movement freedom. That's what it signifies. But we do prescribe something without actually decoding the disease properly, or we do a little bit of misinterpretation that happens every time in clinical practice, because clinical practice is all about trial and errors that everyone knows. So what happens in this case is this is a very sensitive area to practice, especially osteoporosis, because one step wrong, we will actually land up with either we cut the trunk away or we don't gain movement freedom. That's what happens majority of the time. So I've been working in a rural setup for the last 11 years to be proper. And to say 15% of the population that we treat are old people, okay, who actually come with impairments which are closely associated with osteoporosis. So there has been a lot of time for me there to get in through different articles regarding osteoporosis, so that I design my exercise program very articulative in nature, so that the patient actually gets the wholesome benefit. So I actually tried to integrate that particular piece of information that I have gained through years with regard to osteoporosis, and I'm trying to share those knowledge papers. I have tried to put it as simple as possible in the following slides. We are going to divide this session into two. One, the first part is going to be about decoding the disease, Okay, and the second part is about the common misinterpretations and how to actually streamline it. Okay, so let us go into the session. So my session is about osteoporosis, misinterpretation. Okay, this misinterpretation is not alone with exercise selection, it's also with the disease process. Okay, so what is our role play in streamlining this exercise prescription to match osteoporosis and help people with impairments or the disease process? So when we say many things about physiotherapy, the role play plays a very critical part. Determining the role play plays a very critical part. So determining the role play with osteoporosis is all about, I will say, risk mitigation. Okay, mitigation is making things less serious. Okay, so osteoporosis cannot be treated, okay, very effectively, but it has to be a continuous process without errors in a long-term perspective. So it's all about risk mitigation, how safe that we actually play through with exercises. So it's a metabolic bone disease basically, with land-ups with a lot of strength deficit, which ultimately leads to a fracture. Okay. So what does World Health Organization say about this? They take the peak bone density mass for a young male or a young female. When you see the curves on the right and top corner, you will see male definitely has a higher bone peak mass at the age of 25 to 30 comparing women. That puts women to a high vulnerable zone when it comes to osteoporosis. And there is a delicate balance which is there through life between the bone formation and resorption ratio. At that 30 years of age, if a person, say example, suffers a metabolic disease or is of sedentary nature, we are going to discuss all those things later. I'm just giving you two classical examples. When he falls into a category of metabolic disease or he exhibits a sedentary nature, then his bone resorption rate takes over, and there where the osteoporosis starts all again. So a very serious consequence will be a spinal fracture or a hip fracture that is quite prevalent with osteoporosis. We are not elaborating much on the disease because it will consume much of the time. The speculated time has been only 45 minutes. So I will throw a lot of lights on exercise prescription rather than actually decoding the disease. So the only thing which we need to know is Wolfslaw, sequential compression and tensioning cycles, which creates a small electrical potential which acts as a bridge for the bone architecture to be framed again and again in the life. Okay, when this thing is going to happen in cycles, you should, I'm specifying the word cycles because the weight throw has to be in cycles. It has to be a compression followed by a tensioning. If there is continuous loading, the bone is going to be destructed. It's going to be a continuous traction. Once again, the bone is going to be destructed. It has to be happening in cycles. It has to be compressions and tensile force, which has to fall on the bone periodically in a very nice sequence so that the bone health actually is preserved through the life. So bone is a dynamic tissue that it adapts to different loads and requirements for different peoples. And we know exercise is the most recognized method of actually going about it. So if you need to develop a bone or to maintain a bone, exercise plays a very vital part. As physios, we have autonomy over movement system in the body. So whenever it comes to a delicate balance about the bone mass, it is all about physio's prescription of an exercise, and it's about determining the proper dosage. So what leads to when osteoporosis is diagnosed, we see 2 to 3 folds increase in fragility fractures that occurs both in male and female. The only notable factor is women are experiencing more fractures than men. When it comes to fractures, which happens majority of the time, 50% of the women or 70% of the men who sustain low trauma fractures, fragility fractures, it is mostly at that point of time, we actually check out a t-value, DEXA value, and then we see DEXA scan, and then we get diagnosed as osteopenia, the the precursor to osteoporosis. So let's look into the epidemiology. This is one study which I'm trying to quote because this is an Indian study which is published in the International Journal of Women's Health. There are some salient features which you need to see. More than 230 million Indians are over 50 years of age in 2015. And 20%, that's 46 million of the women are diagnosed with osteoporosis. 400 per day in 2013, calculating a regression equation, it takes up to 500 per day in 2022 are experiencing fractures. And in that, 1.6 million fractures are of hip, which are femoral neck fractures and intertrachonitis fractures. And out of that, 1.6 million people, 75% are women. The second to fall in the category is spinal fractures, which mostly happens at either the lumbothoracic junction or at the lowest part of the lumbar vertebrae. And the following third category are fractures like Colles, which is more of to do with wrist and elbow. So I was looking into this one study, which was actually which we need to actually look into, which says that we are the people who educate about osteoporosis on the last of the table. Majority of the information for a postmenopausal women comes from media, friends, and newspaper, whereas we medicos and doctors who need to educate more are pretty lagging, and we are actually falling short by a very long margin, because we are the listed fourth in the study with only 20% actually doing the job. So this is my first message for the physio community. We need to do a lot of awareness programs on osteoporosis for women and men in the community, running through different journals, because this is where we are lagging. So one step, actually educate. That too, we need to educate more when it has to be in the sense of a preventive version. We need to go into schools, especially girls' schools, and then educate them about the importance of exercises and osteoporosis, so that I'll be projecting a slide later which says that if a person achieves 10% of increased bone density at an younger age, or at an adolescence or early adulthood, he is actually postponing osteoporotic changes or osteoporosis oriented fractures by 13 years. 10% increase in bone mineral density at a very young age is postponing osteoporosis by 13 years. So this is the zone where we need to work very intensively, so that we actually fight osteoporosis to a greater quotient. So I'm introducing this word. This is relatively a new word called sarcopenia. Okay, sarcopenia is about muscle loss without a disease process. This happens at the 5th decade in men and 6th decade in women. When we see the point here, the decoding, I said about decoding the disease. When we see what are the fibers which are actually lost, they are actually fast twitch type 2 fibers. They are not endurance fibers. In the muscle, we have a proportion of endurance fibers and fast twitch fibers physiologically that everyone is aware of. But when it is sarcopenia, a muscle loss without a disease process, okay, it's fast twitch fibers which are actually lost more than endurance fibers. So when there is relatively a low muscle mass, which will lead to a more low muscle strength, we know that cross-sectional area is directly proportional to cross-sectional area is actually directly proportional to muscle strength, and it is also directly proportional to majority of the cardiovascular ailments and metabolic diseases. Okay, there's been a request to add a headset. Let me try that. Am I audible?
Yes.
Okay. Okay, next, the important part about decoding the disease will be knowing the classifications of the disease. So we will go into a disease-oriented classification. It says it's primary, senile, and secondary. I listed a few things about primary, senile, and secondary. So we will legibly go through this because this plays a very big part in prescribing exercise. So type 1, we have a trabecular pattern failure, and mostly it's the spongy bone which is lost. It's about, it starts about at 30 years of age, progresses and becomes very prominent and accentuated when an estrogen deficiency is seen in a woman. And when it enters the phase of menopause for a woman, it is very much distinctive. So once entered into menopause, 2 to 3% of bone density loss is observed in the first 5 years itself. Men aged 45 to 50 also experience the same primary form of osteoporosis once they sense a reduction in testosterone. So when we go into the type 2, it is senile, which is mostly observed in age group of more than 70 years, where cortical bone loss is more than actually a spongy bone loss, rather it is more. Women's are once again 2 times more sufferers than men. And here, rather than primary, it is more of a vitamin D deficiency or a poor intake of calcium, which leads to a senile osteoporosis. When it comes to a primary osteoporosis, most of the time it is estrogen or a testosterone deficiency. The third variety of osteoporosis is called a secondary osteoporosis. It may happen at any age. I repeat, it may happen at any age, and it is because of a chronic metabolic or a nutritive disease, or it is either a alcoholism or a long-term medication. These are the factors which are associated with primary and secondary. I never put senile because it is about cortical bone loss. It is purely because of a calcium or a vitamin D deficiency. So associated with primary are increased age, Caucasians or Asians race, or when the patient doesn't, even if he knows that he has an hormonal estrogen deficiency and he has failed to use a hormonal replacement therapy. As I already mentioned, a physical activity deficient person, which is of very low threshold, excessive alcohol intake, and we have a definition for that, more than 2 drinks per day, and an excessive coffee of 5 cups per day, tobacco usage, or a BMI of less than 25.1 kilograms per meter square, fractures or family history of osteoporosis. These are the factors associated with primary osteoporosis. When it comes to secondary osteoporosis, as I have listed some diseases there, chronic and systemic diseases like ankylosing spondylosis, systemic lupus, COPDs, HIV, AIDS, irritable bowel syndromes, leukemia, you can see osteoporosis. This may happen at a younger age too. Medications which involve mostly anticoagulants or anticonvulsants or corticosteroid therapies or long-term heparin usage also lands up with osteoporosis. Excessive alcohol intake or vitamin deficiency, D deficiency or celiac diseases to land up with osteoporosis. And endocrine and metabolic diseases or athletic amenorrheas or Cushing syndromes or type 1 or 2 diabetes also are associated with osteoporosis. The only factor which differentiates the primary and secondary is secondary osteoporosis may happen secondary to a disease process or a metabolic disease process, or it's because of a drug intake. It may happen at any age. Whereas primary, it starts at the 3rd decade or the 4th decade, gradually progresses with a spongy bone loss, and at 70 when it enters into a cortical bone loss. So here I am trying to spell out an interconnection. This is a paper called Osteoporosis and Sarcopenia. Are they 2 different diseases or one? It's a beautiful paper which has actually correlated sarcopenia. I told you sarcopenia is loss of muscle without a disease process, and it has correlated with osteoporosis. To be very surprising that all the 3 stages of sarcopenia and all the 3 categories of severity based classification of osteoporosis, osteopenia, osteoporosis and severe osteoporosis category are actually severely correlating. Okay, so when you see pre-sarcopenia, it's already correlating with osteopenia. Sarcopenia, it correlates with osteoporosis, and severe sarcopenia correlates with severe osteoporosis. So the study says that it is not 2 diseases, but they are interconnected. And this is the second factor which we need to take account into, because you would see a muscle loss parallel to a bone mineral density loss with osteoporosis. Okay, so whenever we treat a bone with exercise, it is mandate we will have to treat the muscle also with suffering with osteoporosis and sarcopenia. Okay, so that's what we actually do. We prescribe strengthening exercises as well as impact training. One is to actually counteract the bone loss, and another one is about increasing the bone mass. But here a key feature that I mentioned in my earlier slide is here the type of fibers lost in sarcopenia are type 2 fast twitch fibers. Okay, they are dominantly seen in mobilizers, okay, which are fast twitch. Manner the exercises prescribed. This is a clue for us to prescribe an exercise, and that's the frequent misinterpretation which happens with prescribing an exercise. When the muscle loss is about a type 2 fast twitch fibers, when we are going to spell a low intensity progressive resisted exercise for the same, it's not going to match the purpose, and that is the first misinterpretation that happens. So it all matters how we decode the disease. That's what I've been telling about. So the loss in the muscle is about a fast twitch fiber, and the bone loss is because of a reason behind. So the treatment has to be identification, or we need to first classify the disease, whether he is falling into a category of a primary, a senile, or a secondary osteoporosis. So because when we land up with a secondary osteoporosis, it is closely associated with either a medication or a disease process. So pharmacological treatment plays a very important part. If it is a primary osteoporosis, once again, hormonal replacement therapy is a very important part in actually preserving the rest of the mineral density. Only exercise won't work. So the recommendation or a standard prescription for an osteoporosis is about combining the right pharmacological treatment. I repeat, combining the right pharmacological treatment with a dose appropriate non-pharmacological, that is exercise medium, to see a visible result. So my exercise prescription is about these two papers. Okay, so these two papers actually give a very large insight into osteoporosis prescription. So this session's goal is about to provide a specific exercise recommendation for prevention and management of osteoporosis within the limit of existing evidence. So these are the two evidences that we are actually looking into. One is actually a meta-analysis study targeted exercise therapy for osteoporosis. Another one is about a positional statement by Exercise and Sports Science Australia, which actually gives you everything in precise. So I told you before going into, we need to design the principles. The principles here are very clean and right. It's only 4. Okay, the first one being disease prevention strategies. I have spelled a few things before itself. We need to create a lot of awareness at a very young age group category, that too especially females, so that we encounter osteoporosis later in their life. Part 2, that will be the preventive aspect of the disease where we need to work into. The second one is about attenuating the bone mineral density, BMD. And the third one is about risk mitigation. Once again, I repeat, mitigation is about making things less severe. And prevention of impairments. Prevention of impairments is all about a faulty exercise prescription which leads to knee pain or stress fractures and osteoporosis, which are actually spelled out in a lot of papers. So a comprehensive exercise program is about throwing a lot of focus into reducing common impairments and injuries, either associated with the disease or associated with the exercise prescribed. So exercise prescribed here has to improve strength and mobility and has to increase the bone mineral density. So every paper has actually prescribed exercises for a minimal period of 6 months or more to show a bone mineral density change. I repeat, every study that we have gone through literally 32 papers. Most of them are meta-analysis and systematic reviews, and majority of the studies have been conducted for a time period of at least 6 months to provoke or show a change in bone mineral density. So here we need to be very rational in prescribing an exercise program for osteoporosis, because the margin of error is very, very, very lean. So irrational prescription will definitely lead to an injury. So if a patient, you can see majority of the patient, when you ask them to do a squat, a overhead squat, they will express a very high degree of dynamic valgus change that we commonly observe in our clinical practice. And we see it pathetically in even 16-year-old these days, because they have a very, very, very poor squatting ability. Squat is one of the most recommended exercise for osteoporosis early in the age, even later in the age. So if the patient is much obese and he has an element of alignment issue, then definitely an irrational exercise prescription, like, say, for example, there are a few people who prescribe right away skipping as an exercise prescription for osteoporosis. If a patient is obese and he exhibits dynamic valgus, you are going to actually rupture either the ACL or the medial meniscus to a greater quotient, and the patient is going to be completely sedentary after that, which is going to rather decrease his bone mineral density, and he is going to literally die because of that. So an under prescription, here is the question. So the next slide is all about under prescription. So here are the dogmas and misinterpretation. So we have studied through a lot of meta-analysis and systematic reviews. I have quoted a few there. Any form of aerobic exercise or a low impact exercise has not shown any notable stimulus to the bone or increase in bone mineral density. So any prolonged, even if it is done prolonged aerobic exercises may create a reduction in adiposity or a cardiometabolic factor change, or it may improve respiratory ailments. But when it comes to a question of prescribing an aerobic or a low intensity exercise for an osteoporosis, it's not going to do a single change with bone mineral density. That has been not my word, it has been from most of the meta-analysis and systematic reviews. So going into how to rationalize, these are the 4 questions that I put always to my brain, okay, before actually designing an exercise program. The first question goes like that: who the patient is, what is his age, what is his disease classification, what are his ADL needs, whether he needs to climb 4-story building every day, or he needs to do a little bit of jumping every time in front of his home. There may be gutter. Old age people, we usually in community see avulsion fractures or fractures of stress fractures. Usually this is the condition that we see. Patient tries to do a large step in front of the gutter and right in front of his home, and then land up with an avulsion fracture. So that's where we diagnose osteoporosis rather. And if at all he is a sporting person, we need to know his sporting needs. That's the first question all about. Who the patient is, his age, disease classification, ADL requirements, and sporting needs. Then comes what is the exercising capacity that accounts for the initial level of fitness, his alignment issues, what is his compatibility to exercise, what are his comorbid factors, and how about his old injuries. He may already have a knee injury, a torn ACL, or he may have a few spurs in his heel, which will actually prevent us to prescribe any impact exercises. So the third question runs is my prescription articulating and effective? If it has to be articulative, it has to be safely progressed without an injury, and there has to be at least a few spike waves in BMD change at the end of 6 months. These are the 2 outcome variables that we need to check after 6 months. It's not about prescribing exercise. Documentation is accountability. We need to create accountability by documenting. So when it comes to a question of documenting, we need to take the bone mineral density change after the 6 months, so that we actually have articulated a proper exercise program into the patient circuit. And last but not the least, it is whether we need to see whether the exercise prescribed are governed by the current available evidence. That's what we do, evidence-based practice. So that's the common misinterpretation that we saw. Okay, any form of aerobic exercise, because the first prescription for osteoporosis is start walking. I know majority of the time it is actually spelled, and people put the word to me also. I have been asked to walk. I have been walking for almost 4 years now, but still I had a fracture. This has been seen very commonly here. This is the reason why I have spelled it earlier. So what does actually the right prescription mean? So I have actually taken 4 meta-analysis and systematic reviews to support what I say now. So this is an overall combination of RCTs and meta-analysis on various age groups. See, it's on children and adolescents, premenopausal women, postmenopausal women, as well as older men. Exercise training involving certain form of weight-bearing exercises. We are going to see what are those certain forms. And progressive assisted exercise, either given alone or in combinations into a multi-model program, can improve bone health. This is what the recommendation made by actually all the studies till date, because these studies are all very recent, ranging from 2013 to 2016. So there is a very simple way of defining what an impact means. So whether it is low impact or high impact, it's very simple. When we prescribe an exercise and both the foot are off the ground, it is called a high impact exercise. That includes any form of jump, running, or plyometrics. Any form of exercise where one leg is grounded and another leg is actually moving, and that form of exercise is a low impact exercise. This is how it is classified. So low impact exercises are not going to do any trade with osteoporosis. It's all about prescribing the right quantity of high impact training. So here are the rules of impact exercises. These are also based on a few papers which I mentioned it down. So the loading has to be dynamic. It cannot be static. It has to be cycles. I told you, Wolfslaw. Wolfslaw states the tension and compression cycles create electrical potentials, which is behind the architecture of the bone. So the loading cycles needs to be cyclic and induce relatively high bone strains or deformation by increasing your body weight on your impact training. So here the recommendations what I'm going to make is we will have to utilize at least 2 times body weight impact exercises to create a change with the bone mineral density. It also states that short bound of exercises with a longer rest interval is actually the right way of prescribing an exercise, because when you do it very slowly, as the nerve habituates, there is a desensitization happens in the bone also. Excuse me. Okay, then the fewer loading cycles. So if it is going to be a fewer loading cycles of the adequate intensity, here the minimal recommendation is at least 10 to 50 per day, at least 3 times a week. Okay, so the 10 to 50 jumps, say for example, per day, 3 times a week is more than sufficient to bring about a change in bone mineral density. Finally, bone is an adaptive tissue. You know, it is an adaptive tissue. It modifies through the years to come, right from our early childhood through geriatric population. It undergoes changes through the part of the cycle, life cycle. So finally, bone will adapt to customary patterns. So when you are going to prescribe a unidirectional exercise, it is not going to do the trade. So osteogenic variables for impact training. These are the variables that we need to consider. Neuromuscular overload, rapid change in directions, just now I specified. Spatial overload, when we need to do a larger range of motion or exaggerated movement patterns to induce bone mineral density. Temporal overload, temporal load is all about timing. We need to improve the rapidity of the exercise. We need to do it rapidly. When it comes to a question of intensity, I told you earlier, it has to be 2 times the body weight at least to induce a bone mineral density change. Volumes, the sessions have to be ranging from 50 to 200. And the frequency of the exercise, I already mentioned it, it's minimum a period of 6 months to show a significant recovery. As it is impact training, we can do only 2 to 3 sessions per week, because we take a longer recovery phase. So recovery phase is about 48 to 72 hours. Okay, so we need to actually prescribe only 3 or 2 when it goes to novice. Novice is inexperienced people. We are prescribing an exercise to a novice category. We need to go only 2 sessions per week, and once they start picking up, once their experience with exercise actually climbs up, then we can actually progress it to the maximum of 3 sessions per week. So when it is impact training, we need to have a very casual eye. Any pain or inflammation, we need to treat that first before entering into an impact training. Any joint instabilities, definitely with impact training, that's going to be a graveyard. Any soft tissue limitations, we need to actually work for before going into an impact training. If the patient, if for example, say impact training means to be rather, it is actually a plyometric form of exercise. So when it is a plyometric exercise, the criteria to enter into a plyometric exercise will be about a very good foundational strength. The patient has to possess at least 90 to 100% of muscle strength bilaterally, so that we enter into a proper plyometric training or a jump training. So if there is an absence of a training base, for example, that's what I mentioned about a novice category. Novice category of people are inexperienced people with exercises. An extra piece of care or a slow progression is considered. So here are some contraindications in progressing the load of the impact training. If the patient in due course of exercise time has very poor coordination or motor control, then we need to pitch it a little bit slower so that we don't land up with injuries and then we fail the mission. Our mission is all about increasing the bone mineral density when it comes to a question of osteoporosis prescription. So first exercise mode, what you are going to see is impact loading. I have mentioned what are the type of exercises. They are going to be any form of jumps which are not unilateral, which is going to be unilateral and are not unidirectional. They will be multidirectional in nature. You can add weights by carrying weights on your back or dumbbells or kettlebells in your hand and then jump, or weight vest. You can wear a waist weight and then increase the amount of intensity of exercises. Here, we are categorized into three: low risk individuals, moderate risk individuals, and high risk individuals. These are nothing but osteopenia, osteoporosis, and severe osteoporosis. We can actually categorize the same way. This is for the sake of prescribing an exercise. So when we see a low risk individual, the intensity has to be relatively high. We can go up to 4 times the body weight. The frequency can be 4, starting with 3 to 4. We can gradually increase it to even 7 per week because they are very low profile or low risk individuals. So I told you earlier, it's about 50 jumps per session, 3 to 5 sets of 10 to 20 repetitions with 1 to 2 minute rest interval. These are all ACSM guidelines integrated into it. And this is also based on Australian science for exercise prescription. This is taken from Journal of Science and Medication in 2016, published in Sports 2016. When it comes to a question of moderate risk individuals, here we are decreasing the load. So the body weight has to be 2 times as tolerable, but the frequency we don't have a change. We start with 2 to 3 or 4, then progress it to 7. The sets and repetitions also don't have a bigger change. Then we go into the last category, high risk individuals. So here we need to go in for moderate impact training. So you can actually go to at least 2 times body weight as tolerable by the patient, but within the limits of pain and the fragility of the patient. But the frequency has no change, and I have questioned this through going through different papers for the safety concern, but they have said it is very, very safe. I repeat, safety concern has been raised for prescribing impact training for a high risk group of osteoporosis, and the answer was it is actually safe. So that was the first prescription, and that goes directly to the bone because impact training is about landing directly on the bone and the changes being replicated on the bone. The second category, we are going to address the muscle. As you know, we saw a study called sarcopenia, which is coexisting or correlating closely with osteoporosis. So when it comes to resistance training, this is the training which is actually the primary form of intervention that we give to increase hypertrophification. So as I already spelled it out, it is about a cross-sectional area which directly correlates with muscle strength. And when you have a low level of muscle mass, it is almost correlated with every possible metabolic disease, okay, cardiovascular diseases, diabetes, and not to surprise, it also correlates with osteoporosis. So here are the principles of progressive assisted training. I will recommend the bottom paper to be read by every physiotherapist because that gives keynote on every possible assisted training which is there on the market till date. It's a paper, very recent paper, It was published in December 2019, which says maximizing muscle hypertrophy. It's a systematic review. They have, it's a beautiful paper. I'll repeat, it's a beautiful paper. Every physio has to go through the paper once in their lifetime to know about progress-assisted exercise. So there are three factors when it comes to a question of progress-assisted exercise. Either you add mechanical tension, that we classified as time under tension, or you increase the metabolic stress, or induce or inflict a muscle damage so that it is repaired and the muscle is hypertrophied. So with regards to a higher degree of mechanical tension, the technique or the mode of resisted exercise training has been an accentuated eccentric load. It's nothing but increasing the time period of a eccentric training, reducing the time period of a concentric training. When it comes to a question of metabolic stress, you need to do into drop sets or SST, sarcoplasmic stimulating training. It's nothing but taking a weight, exercising, okay, and then reducing the weight, continuing exercising, reducing the weight by dropping the weight 1 RM by every 20% every time, and then continuing the exercises so that you have a buildup of metabolic stress, which will directly actually increase your muscle hypertrophication. So the last, tempo of eccentric training. Tempo means it's actually how you pitch it. I will actually come to that in my later slide. So a slower tempo eccentric training, especially during the eccentric phase, contributes more to muscle damage, which leads to muscle hypertrophy. So every time when you perform a progress-assisted exercise, it is being asked to perform till volitional fatigue. Volitional fatigue is, say for example, you take a weight and then start flexing your biceps. So if you don't go through the full range of motion and you do tricks and trades to actually try to convince your gym coach or the physiotherapist that you are accomplishing the numbers, then it is called volitional fatigue. So every time you need to achieve that volitional fatigue to bring about a marked change in the muscle. So there are actually, in that paper, they have listed more than 6 techniques, and those 6 techniques can be used in combinations so that, at least for the sake of monotony, if you give an exercise medium for 6 months, the patient is going to be sensing a lot of monotony and bore. So you need to actually do different combinations, keep the patients engaged physically and mentally so that persistence in exercise and training is achieved. So progress-assisted training, ACSM guidelines, 1 to 3 sets of exercise of 6 to 12 repetitions, 8 to 12 repetitions. And here the notable point is it is done at least 75% to 85% of 1 RM. I repeat, it is done minimum of 75% to 85% of 1 RM for a novice or a beginner or an inexperienced candidate. And 3 to 6 sets of 1 to 12 repetitions with 70 to 100% of 1 RM for an advanced individual. This is the standard recommendation of prescribing progressive resisted exercise. We cannot call, when we're going to prescribe with that above mentioned parameters, it is rather called a high intensity progressive resisted training because the intensity is already 75% and more. So the right prescription for engaging the patient with osteoporosis will be a high intensity progressive resisted training secondary to an impact training. So when it comes, I told you I'm going to mention this. A tempo means when you take an exercise and a dumbbell and then you're going to go out, eccentric, transition phase, once again a concentric phase, a transition phase. The tempo is 2020, means literally you don't hold at the end. Okay, one of the important principles that's been stated by every coach or a physiotherapist in a strength and conditioning world will be never stop at the end or at the locked position of the joints. So after doing this particular high intensity training, what will you observe? At the end of 4th week, this is all from relatively very good papers. This is not from my word. This is all from relatively very good papers, all are systematic reviews. At the end of 4th week, you will see a hypertrophy change in the muscle, and that change is mostly attributed to a muscle damage. At the end of 8 to 12 weeks, you will sense a lot of strength gain. That is purely because of neural adaptations. And at the end of 6th to 10th week, you will see the true gain or the true hypertrophy starts to surface on the muscle. So now going into the exercise mode. So rather, I will call it a high intensity progressive resisted training Once again, the question of safety has been raised, and it has been confirmed that high intensity progressive exercise are being very, very safe, even if it's going to be prescribed for a high risk individual. Now I am going to say it, I have already mentioned it, about 8 exercises per session targeting major muscle groups and mostly to the hip and spine. This is the articulative part that we are speaking about. The articulation is all about decoding the disease. You know about the exercise pattern, whether you are fitting it right to the particular person, articulating it. So here we saw in the disease, the first was more of a hip fracture and more of a spine fracture. Then the last category was more of a wrist fracture. So when it goes into actually prescribing exercise for osteoporosis, it's all about prescribing large group of muscles which are more oriented with the spine and hip to be the dominant category for a beginner, because that's where you have a fracture with later. So weighted lunges or calisthenic form of exercises are also supposed to be incorporated into the circuit, and a small number of compound movements like deadlifts and squats are also supposed to be added. In what proportion you add, when you start, when you end, where does the exercise actually articulate? It's all question of manipulating, not with trial and error. Because once you do a trial and error with a normal person, it's going to be a minor strain. But when you're going to do a trial and error for an osteoporotic patient, then the patient is in vain, because he is going to land up with a stress fracture or a big fracture that will relatively put the patient to bed and rather death. So now, going into a low risk individual, the intensity, there is no question about intensity here. Its intensity is always high or very high. As the person is at low risk, here it is tried to be incorporated mostly into a combined or compound movement pattern, or it's going to be a more of a calisthenic form where you include weights with. So here the question of cardiovascular comes into an issue, because you are doing a high intensity exercise for an older population. So we include the Borg scale, where the rating scale of 20, you see an exertion index to be more than 16 or equal to 16. That's a safe limit to exercise, standard recommendation. The frequency will be 2 days per week, sets and repetition 2 to 3 sets of 8 reps. And here are the few factors, the articulative factors: high velocity, rapid. You know how to correlate this? It is high velocity rapid for the only reason because we see a muscle loss of only fast twitch fibers in sarcopenia, or in osteoporosis. Muscle loss is only of type 2 fibers. So if you don't include the parameter of rapidity, you are not going to work that particular muscle, and the muscle is not going to hypertrophy, and rather it's not going to add to the end result. So the only concern here is avoid deep forward spine flexions. Training techniques are always supposed to be supervised mandatorily in every category, whether it is low, moderate or high. So now we jump into the second column, moderate risk individuals. No change about the intensity, the Borg scale, the frequency is all about the same. We have no change at all. The only thing is we need to avoid spine flexion at the extremes. So when it comes to the higher risk individuals, we will actually once again do the same intensity. I told you we are prescribing only high intensity progressive training. So apart from rapidity, here our concern, even if we don't supervise a low risk individual, supervision is of a mandate for a higher risk individual group. So we have seen two varieties of exercise prescription. One goes with impact training, second goes with high intensity progressive resisted exercise, and third one, we know that osteoporosis, risk of fall, higher age group, so balance we cannot miss. So a multi-model program for an osteoporosis includes impact training plus high intensity progressive resisted training plus balance training mandate into a osteoporosis program. So according to Shambay-Cook, balance is a highly task specific thing, and they have actually divided balance into 3 categories. It's static or dynamic balance, which means maintaining a steady position in sitting and standing; proactive balance, which is anticipatory control; and reactive balance, which is real-time balance to a perturbation or a disturbance. So the standard equipments, these are also from studies. So the standard equipments used in studies to treat an osteoporosis or a balance training for osteoporosis are Bosu ball, tilt board, foam mat, balance platforms, or computerized balance system, where high amount of inter and interreliability is there for bioducts balance system. So these are the instruments used to train balance. So difference in balance training is actually a mandate because every person has a different level of balance. Even a person of the same age group experiencing a same disease and falling into the same category of an osteoporosis will have different with balance. So it has to be tailor stitched. There are some critical markers which has been given in majority of the studies. These critical markers are when will a patient be classified as a high risk for falling category. Very simple. If his standing time is less than 19 seconds in a modified Romberg scale, point number 1, his habitual gait speed has reduced by 1 meter per second, and his duration is more than or equal to 13.5 to complete a timed up and go test. These are the 3 criteria which has been marked in majority of the studies as critical markers to judge on a patient's risk of fall, especially in old age. So this is also a beautiful paper which judges the dose response relationship in balance training. So here I give the recommendations based on that study. The training period is anywhere between 11 to 12 weeks. The frequency of the training is somewhere between 3 sessions per week. And majority of the studies, they say they don't do a balance training separately. They integrate the balance training into the high intensity resisted training or into the impact training itself. The volume has to be 36 to 40 training sessions to induce a little bit change in the balance. Duration of a single training session is somewhere between 31 to 45 minutes. Total minutes per week is somewhere between 91 to 120 minutes per week. So these are the effective parameters in improving overall balance performance. This is based on a study. This is also a systematic review and meta-analysis. I have quoted the study below. So coming into the third category, balance training, we have standard ways of improving or increasing the prescriptions for balance training. It's about standing and moving from static postures, reduce the base of support, include exercise forms like Tai Chi, or we go into changing of the surface on which the balance is being exhibited from foam mats to beams. We do things faster, starting slowly, and then we do it faster to gain balance. We do morely with reducing the base. We include the weight of the arm as a tool to progress with balance. We try to withdraw the vision by actually asking the patient to close and then do the same thing. These are the standard techniques that we actually use. These are the techniques being recommended here too. Now, here when it questions when we go into the categories, the same categories, low risk individuals, the intensity has to be really challenging. The intensity remains challenging because here the overload is a challenge. Frequency for a low risk individual, they say balance training is not being done separately. It is being incorporated into the standard other training procedures. When it comes to a moderate risk individual, the intensity remains the same. The frequency is 4 sessions per week. Repetitions 30 minutes of varieties of balance. Following, you have to prefix and suffix with some form of movement. We cannot actually keep doing one balance exercise one after the other. And every time here, important stuff is actually you need to have a rail before the patient so that the fall is actually tried to be prevented. So balance training, there is one systematic review says that the Otago home exercise program is very effective for a very old category. The Yang style Tai Chi is recommended in majority of the situations. We will see some recommendations because these are the common things that we counter. One is how do we modify for arthritis? If at all the old age person has a neuromuscular impairment or a fragility, what we do, and what in case of a cardiovascular disease. So when it comes to a common question of modifying for arthritis, it's all about aligning, loading it proper, reducing the range to a pain-free zone, and individualize the intensity. When it comes to a high impact exercise, we need to reduce the heel. We have to reduce the ground reaction force, basically. That like we start with heel drops rather than starting with jumps. So here, instead of impact exercise, we can do more of a progress-assisted exercise in this category. Balance training, short sessions, not prolonged loading of weight-bearing joints, reducing the angles of flexion during a Tai Chi, or delay of one leg balancing earlier. Don't prepone the exercise. Modifications for neuromuscular training will be purely based on compatibility for progressive, because we know with the neurological impaired patients, it's very difficult to actually go for a progressive exercise, but it needs immense supervision. When it comes to a question of high intensity exercise for a neuromuscular, start with heel drops, the same recommendation. It has to be supervised and rail has to be mandatory. When it comes to a question of balance training, once again, supervision and the progression of the exercise needs to be really, really slow. When the considerations for a cardiovascular or a pulmonary means, you'll have to still stop well within the limit of a provoking angina. No Valsalvas, keep the intensity very, very low. But when it comes to a question of balance training for a cardiovascular or pulmonary disease, there are no modifications suggested. I told you this is the last thing. We are coming almost to the end of the session. Risk mitigation means if at all the patient already has an injurious fall, what are you going to do? Prescribe balance training, progressive training prior to a balance training, optimal lighting, visual aids, safe footwear, splints, review with the medications, because majority of the time older people, they have medications. The medications are behind their hypotension or their spin. When it comes to a question of a pre-existing spinal fracture, we need to avoid spine flexions, no twisting movements. We will have to entertain more of good sitting and standing postures. We need to modify their leisure time activities like gardening, sweeping, and biking. So when the patient has a processes, say for example, the patient already has been a patient of a hip replacement, you need to avoid internal rotation and hip flexion to a greater quotient. Pain for as it correlates with the processes, what has been replaced. Pain for osteoporosis, if it's osteoarthritis, then we recommend low intensity exercise. It is about a low impact exercise, or you replace low impact exercise with a more of a progressive assisted exercise. So when it is going to be painful, you go for, or it is going to be a fracture or a dislocation earlier or an unhealed fracture, you will have to give the right amount of time, double the time, wait for it to heal properly, use proper braces while exercising, or collaborate with a physician, use analgesics during exercise. So what will be the outcome? I told you. So a study, these are some studies which we looked into for the possible outcomes. The outcome here is very, very, very clear and straight. Whatever you prescribe has to be showing an increase in bone mineral density, or else whatever you prescribe is not authentic or it is irrational. After intervention of a high loading capacity exercise for a minimal essential threshold for 6 months, it stayed for 12 months. Whereas when 18 months of training was given and a follow-up period of 3.5 years was followed up, we didn't see the same change that happened exactly after the 18 months, which didn't last for 3.5 years, which puts that exercise has to be a regular part in their life if it is going to be a osteoporosis diagnosis. So when I'm going to not drop this slide, then it is not a complete presentation. I told you already, achieving 10% of more peak bone mass is going to be delaying the osteoporosis by 13 years, delaying the fractures by 50%, and to be frankly saying that adaptation to mechanical load happens in younger bone more than older bone. So skeleton is more responsive and adaptable in childhood than in adulthood. That everyone knows because it's flexy. The benefits of a targeted exercise appears to sustain even after intervention. When the last slide says after 3.5 years follow-up, the bone mineral density was not of the same. But when the same study was done in early childhood, it stayed. Means we have happy news. Means when you're going to prescribe the right amount of exercise in an early childhood, adolescent, or an early adulthood, then those changes inflicted on the bone mineral density is going to be static, or it's not going to decondition. So it is never too late. Exercises for postmenopausal women have also shown results. So it doesn't matter that wherever you prescribe, exercise is a very good tool for osteoporosis. If it is being prescribed rationally. So I'm summarizing: muscle loss, decreased bone mineral density, balance deficiency, decoded the disease. Recommendations: high intensity progressive assisted training, high impact training, balance training. Older population are with intense exercises loaded. So it's a very careful phase for every physiotherapist, but physiotherapists hold autonomy over human movement. So it is only we physiotherapists who can actually do the trick. No other professionals can do the trade here in maintaining the osteoporosis or increasing the bone mineral density for osteoporosis, because we are the persons who hold autonomy for movement. We are proud to be physiotherapists. Thank you.
Thank you, Sandil, for a wonderful presentation. I request all the participants to please put questions in the chat box. Okay.
Thank you, Sandil, for that very comprehensive
presentation.
Thank you, ma'am.
A
very evidence-based presentation. Especially, you had taken a lot of strain, I can see from your slides, in preparing them from getting studies which are the latest with empirical evidence. So I'm sure the participants have well taken this session. And this has thrown a great light across the tunnel, because still there are many who do not know how to deal with osteoporosis. I think the major problem is when you don't know whether it is osteopenia or osteoporosis.
Yes, ma'am.
So when your patient comes to your clinic or to you for an advice, the first question that a physio has to ask is not only the demographic data. Today, so much of importance is given on documentation. I feel that these sort of questions too become mandatory in every form that you fill, because there are many times when you miss osteopenia and osteoporosis, and we ourselves may be the reasons for giving a fragility fracture.
Yes, ma'am.
So let us, the motto should always be do no harm. Whether you do good or not, you do no harm to your patient. And this is an area where there is a possibility of doing harm to your patient because of ignorance or because of negligence. So this is an area that has to be well addressed. And this session has given a wide view on how to do a differential diagnosis. And you have touched upon, I'm very happy that you touched upon the part on cardiovascular, because calcium is a very important factor as far as the heart is concerned too. So you need to definitely ask questions on that too when your patient comes with osteoporosis, diagnosed and interpreted by the physician, when the person is referred to the physio for exercises, and exercise prescription becomes your priority. It has to be a question that is mandatory and should be incorporated in every physio's form. So this is the type of documentation that is needed. So thank you for that very, very wonderful presentation. Proud to say that you are our alumni. And I thank Yashoda for identifying you and bringing you here to this wonderful session here, and for giving this participants who've been very fortunate to attend this session too.
I'm blessed. Thank you, ma'am.
Thank you so much, Sandil. There is one question. For type 2 twitch fibers, we will not recommend low intensity exercise, even initially. Is it so?
Yes, exactly. That's what we have been, that's what I said about decoding the disease. Decoding the disease says it's type 2 fibers, which means it's mobility fibers. The fiber has to be addressed with a higher intensity and rapidity, or else the muscle is not going to respond. So when we take evidence, the postural fibers, when we are going to treat a postural fiber, we need to do breathing, and the MVC has to be 30%. When we are going to work on a fast twitch fiber, rapidity quotient as well as a higher load is mandated to stimulate the fibers.
Okay. Any relation of vitamin B12 deficiency with osteoporosis?
There are many, ma'am. There are many, hell a lot of factors actually. Too many to touch into, like COVID.
Okay. And one more we have is, sir, as you said, high impact training in old age, severely osteoporotic patients is safe. Yes. How is your experience about it, and have you come across any?
Yeah, we do have actually come across. The thing is, that's what I've been speaking about, how to go rationally about it. We need to look into the alignment factors. Okay, and I actually mentioned a single thing about start with heel drops. Heel drops is a manner where we stand on a platform and then just drop the heel to impact the calcaneum. We go with very low impact exercises and then slowly start climbing up for a very severely osteoporotic patient. I have actually come across a few people where we have not prescribed anything bad till now. Thank God for that. We have not landed up any people with fractures or even stretch fractures. the recommended exercises has been good in the recent past. I don't know about documentations in my early career, but last 7 to 8 years, I can say I've been very rational in prescribing exercises for osteoporosis because I work in a rural setup. People know about me. I work in a rural setup. Every possible patient who comes with an arthritis knee is osteoporotic or osteopenia. So we prescribe exercises like we start with squatting only. We start with squatting and heel drops every time. So I have not actually experienced anyone, or I have not prescribed any exercise irrationally to bring about a fracture till now in my life. Thank God for that.
Okay. One more question for a person who is in 20s having regular pain in legs during later end of the day. Can that be due to low BMD? And can we start with general isometrics and the squats thereafter?
So once again, as a clinician, if you want me to answer, I will have to see if it's bilateral and it is crampy in the evening. You'll have to rule out arterial complications. It could be anything of a claudicative type. Rule out that and then start exercises, because that's the only concern. Ma'am will be very happy on seeing this, me speaking about peripheral vascular disease, because she used to scold us every time to study peripheral vascular diseases. That's because we are here now. So when it's going to be evening, crampy pain, it is more possible of a vascular disease. So we need to take a Doppler, rule out those diseases before prescribing any exercise, according to me, ma'am.
Okay, and how
I feel, can I add on that? Because even hypocalcemia can present with symptoms, because at a younger age, you need not worry about this. You definitely need to look at your calcium levels and also find what activity you do the entire day. So that also matters, because even a mild fatigue can also give the same symptoms. So need not think too much about it. So considering the age of the person who's in 20s, I don't know if you're early 20s or late 20s, also look at hypocalcemia, because that is the age where you tend to, sit always inside an AC and you don't move around much. And of course, your sun exposure is less too. But all this need not be osteoporosis too.
But
nowadays, ED is very important. Differential
diagnosis, because we could see bilateral pain in claudications, neurogenic claudications too, because we are seeing worst spines possible these days, even in 16-year-old categories. So we need to rule a lot of things out. First in the list would be anything arterial, then it will be anything neural, and last will be we'll have to look into any calcaneal dysfunctions, because loading, if it is different, then it will raise a question of stability concern, ma'am. So where we can see
gender matters.
Then gender matters solely as
if it is at 20s, and it can even be due to menstrual cramps. That can also be a reason. So many things are there into it, like you said.
DD is the answer.
Last question: How to heel drop with jumping? Any demo, sir?
No, please.
How to heel drop with jumping? Any demo, sir?
Demonstration, maybe I will upload a video later.
Okay. With
Sunday afternoon after my biryanis, I cannot jump.
Okay. Patient with TKR or THR, is it advisable to start with high impact exercises? If yes, what kind of impact exercises to be started? Dosage.
No, I am very specific in my prescription. If at all a patient has a TKR done, internal rotation or degrees of flexion needs to be the first primary concern. Take into question, if the patient is ambulant, he has to actually take some form of impact in his ADL activities. We'll have to do a score sheeting of any index. We'll have to take any functional index into question. We'll actually question him what is his requirement. That's what I mentioned in my rationale. So if the patient requires a little bit of impact every day in its life, then no question about it. We will start with heel drops. We will make sure that he does only smaller ranges, and he doesn't do internal rotation of the hip or excessive hip flexion, and then we will slowly progress. But what does the patient's need? What functional needs does the patient need? Based on that, we will actually prescribe, ma'am. We can, but it has about pitched at a very slow pace. We'll start with heel drops, lesser range, no internal rotation of the hip, no excessive flexions of the hip.
Okay. Thank you so much, Sendil. It was Dr. Sendil, it was a very wonderful insight. I will say updated and evidence-based insight in world of osteoporosis with a beautiful rationalizing and a dosage-based exercise prescriptions. And with that, I will thank you all the participants for patiently being with us. Thank you, IAP India, for providing us this platform. Thank you so much.
Thank you. Thank you, ma'am.
The rest of the questions can be answered by email. There are still questions that come in. I think that's for the participants. They can see the answers in their mail if they give the mail ID too.
Okay.
Oh, thank you.
Thank you on behalf of IAP technical team. I thanks to Sandil sir for the wonderful and informative session. I hope every participant acquire knowledge, and thank you Supriya ma'am and Yashoda ma'am for organizing such webinars. I extended my thanks to Dr. Sanjeev Jha sir, IAP president, and Dr. Ruchi Vashne ma'am, IAP treasurer, for providing us all this platform. Again, I request to all the participants, please like and subscribe IAP India YouTube channel and follow Facebook page. Thank you so much.